Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's June 2022 issue. There are 3 articles which have been selected as our editor's choice or highlights articles this month. The editor's choice this month is a thematic review article that is entitled Skeletal Aging. It is authored by Dr. Jad Sfire and colleagues from the Robert and Arlene Kogut Center on Aging and the Division of Endocrinology and Metabolism at Mayo Clinic in Rochester, Minnesota. Aging predisposes to chronic disease and multimorbidity, prominent among which are osteoporosis and its complications. In their review, Sfire et al. Expertly discuss the epidemiology, risk factors, pathogenesis, and treatment of osteoporosis within the overarching framework of age-dependent skeletal changes and processes. As noted by the authors, in Americans aged 50 years and older, osteoporosis is present in more than 10% of Americans, with 1/3 of women and 1/5 of men developing fractures at age 50 years and older. The authors discuss such salient areas that include the assessment of skeletal fragility, the assorted factors which, along with aging, promote bone loss and fractures, the assessment of falls, frailty, and sarcopenia, the critical relevance of hormonal status on bone health, and the natural history of changes in bone. With regard to the latter, in the first 2 decades of life, bone modeling occurs, with peak bone mineral density occurring in the 3rd decade for either sex. From the 3rd decade onwards, bone remodeling occurs. Besides bone mass and mineral density, the bone microarchitecture and material properties of bone may determine the risk for fractures. These characteristics may be affected by aging, type 2 diabetes mellitus, and glucocorticoids. Remodeling of bone consists of cycles of resorption by osteoclasts, reversal by bone marrow-derived osteoblast precursors, bone formation by osteoblasts, and bone mineralization by osteocytes. Osteocytes aid in the coordination of the actions of osteoclasts and osteoblasts, and these remodeling cycles are influenced by mechanical stress and bony microdamage. By the 5th decade or so in women, at the time of menopause, and later in men, the balance between bone resorption and bone formation is tilted towards net resorption. As noted by the authors, it is estimated that women and men exhibit lifespan losses of 55% and 45% of trabecular bone respectively, and losses of 25% and 18% of cortical bone respectively. Such net loss of bone may reflect, at least in part, increased death of bone-forming cells, increased marrow adiposity, and the accumulation of senescent cells, which produce an inflammatory senescent secretory phenotype. Sfire et al. Conclude their review by discussing and emphasizing the prevention and treatment of osteoporosis by physical activity, calcium and vitamin D, and pharmacotherapy with estrogens, raloxifene, bisphosphonates, and other therapeutic compounds. Reducing the risk of or treating osteoporosis by such approaches, as indicated, in turn reduces the risk of fractures and the attendant morbidity and mortality. The first highlight article this month is an original article entitled The Prevalence and Natural History of Mitral Annulus Calcification and Related Valve Dysfunction. It is authored by Dr. Nahoko Kato and colleagues from the Departments of Cardiovascular Medicine and Health Sciences Research at Mayo Clinic in Rochester, Minnesota. Mitral annulus calcification is characterized by 3 essential processes involving the fibrous annulus of the mitral valve, specifically chronicity, degenerative changes, and deposition of calcium. Cato et al. Undertook a large retrospective analysis of adults undergoing transthoracic echocardiography in 2015 at Mayo Clinic, Rochester, in whom mitral annulus calcification was identified. In this population of almost 25,000 patients, the prevalence of mitral annulus calcification was 23%, the latter increasing with age. The mean age of patients with mitral annulus calcification was higher than those without this condition, namely 75 years versus 60 years. Mitral annulus calcification predisposes to mitral valve dysfunction. Specifically in this patient population, mitral regurgitation without mitral stenosis occurred in 9.5% of patients with mitral annulus calcification, compared with 6.1% of those without this condition. The analogous figures for mitral stenosis, irrespective of mitral regurgitation, was 6.6% and 0.5% in patients with and without mitral annulus calcification, respectively. The odds for the presence of mitral annulus calcification were significantly increased by aortic stenosis, prior aortic valve replacement, and left ventricular outflow tract obstruction. Risk factors for mitral stenosis in patients with mitral annulus calcification included aortic stenosis, prior aortic valve replacement, left ventricular outflow tract obstruction, female sex, kidney dysfunction, chest irradiation, and coronary artery disease, whereas risk factors for mitral regurgitation included reduced left ventricular ejection fraction, left ventricular outflow tract obstruction, left ventricular mass index, kidney dysfunction, female sex, and age. After relevant adjustments and during a median follow-up of 3 years, patients with mitral annulus calcification exhibited an increased mortality, which was further increased if complicated by mitral valve dysfunction. This study by Cato et al., the first large cohort study to date of the prevalence, clinical characteristics, consequences, and complications of mitral annulus calcification, shows that this valvular condition is neither uncommon nor benign. The second highlight this month is an original article entitled Socioeconomic Deprivation and Premature Cardiovascular Mortality in the United States. It is authored by Dr. Graham Bevan from the Harrington Heart and Vascular Institute of the University Hospitals Cleveland Medical Center in Cleveland, Ohio, and colleagues from Case Western Reserve University in Cleveland and Houston Methodist in Houston, Texas. Traditional cardiovascular risk factors do not adequately account for premature cardiovascular mortality in the United States, especially in light of the discernible trends and geographic variation in such mortality. Bevan et al. Examined whether socioeconomic deprivation, increasingly recognized as a determinant of disease, may underlie such regional and temporal profiles in premature cardiovascular mortality during the period of 1999 to 2018. The authors obtained such mortality data at a county level from the United States National Center for Health and Statistics. County-level prevalence of traditional cardiovascular risk factors was obtained from the 2020 population-level analysis and community estimates projects. Socioeconomic deprivation was evaluated by the Social Deprivation Index, which is an integrated score based on income, employment, considerations pertaining to home, housing, and household, level of education, and access to transportation. The authors also employed another validated index, the Area Deprivation Index, which is an integrated score based on 17 criteria pertaining to aspects of income, employment, and education. The findings of Bevan et al. Demonstrate that counties with a higher quartile social deprivation index and area deprivation index had a significantly increased total non-Hispanic, Black African American, and female premature cardiovascular mortality, with both these indices correlating with mortality. Notably, 44% and 40% of the county variability in cardiovascular mortality could be ascribed to the area deprivation index and the social deprivation index, respectively. During the years of this analysis, namely 1999 to 2018, premature cardiovascular mortality decreased, but the decline in mortality was less in counties with a higher socioeconomic deprivation. This, as noted by the authors, suggests widening disparities. The basis for the relationship between socioeconomic deprivation and premature cardiovascular mortality is multifactorial, including, for example, access to healthcare and psychosocial stress, among other factors, and this is highlighted by Bevan et al. In their discussion. These findings underscore that so much of disease processes, in this case premature cardiovascular mortality, have their provenance in socioeconomic deprivation, findings of particular relevance and importance to healthcare policies seeking to reduce cardiovascular mortality. You can access these highlights and editor's choice articles free of charge during the entire month of June. Please visit our Mayo Clinic Proceeding website at www.mayoclinicproceedings.org, where you'll find links to our social media by clicking the buttons at the top of the home page and at the bottom of any page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and author Insights podcast recordings, which are available from our website on the homepage, as well as through iTunes. You'll also find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content, as well as articles published online in press. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.